Good morning, everyone. Today we'll start the male genital tract pathology. The first lecture will discuss penile, scrotal, testicular, and epididymal diseases. We're going to start with some penile malformations, specifically hypospadias and epispadias. These two malformations indicate the presence of abnormal urethral orifice. And instead of opening at the tip of the glans penis, they open either at the ventral aspect of the penile shaft, in the case of hypospadias, or in the dorsal aspect of the penile shaft in the case of epispadias. Hypospadias is more common than epispadias. Both of these malformations can be associated with anomalies in other parts of the body, such as inguinal hernia and undescended testicles. These abnormal orifices are characterized by being narrow, which could result in urinary obstruction. Obstruction means incomplete voiding of the bladder, which implies increased risk of infection. This is a schematic drawing of hypospadias and epispadias. Notice the location of the abnormal openings. The penis can be affected by different organisms, resulting in balanitis and balanopustitis. They indicate the presence of local inflammation of the penile tip. Common offending agents include Candida, anaerobic bacteria, Gardnerella, and these all are predisposed by poor hygiene, specifically in uncircumcised males. The presence of balanitis could be complicated by phimosis, which is the failure of the prepuce to retract easily over the glans. Phimosis can be congenital, but more commonly it is a result of or a complication of repeated attacks of balanitis. 95% of malignant tumors of the penis are squamous, either invasive squamous cell carcinoma or in situ carcinoma. Again, they affect typically uncircumcised males over the age of 40. Other risk factors include smoking, poor hygiene, and infection with high-risk HPV strains such as HPV 16 and 18. Carcinoma in situ in the penis is also known as Bowen disease. It appears as a solitary plaque on the penile shaft, and histologic examination as carcinoma in situ anywhere else in the body reveals the presence of full thickness dysplasia, but no invasion of the basement membrane. Should that invasion happen, the case no longer belongs to the in situ category and belongs to the invasive carcinoma category. Luckily, 10% of carcinoma in situ patients only will progress to invasive squamous cell carcinoma. This is an image of Bowen disease. The upper left image is a normal skin for comparison, while the bigger image indicates Bowen disease. Notice the presence of highly atypical cells in the middle of the field and frequent mitotic figures and dead cells. The arrowheads point towards highly atypical cells, and the the white arrowhead indicates a dyskeratotic or a dying cell. All these features are atypical, and since they are full thickness, this is carcinoma in situ or Bowen disease. Most cases of invasive squamous cell carcinoma are keratinizing, well-differentiated or moderately differentiated tumors. Once again, like many tumors we've seen so far, stage is the most important prognostic factor. For example, patients with localized disease have a 66 5-year survival, while patients with metastatic disease have only 27% 5-year survival. A subtype of squamous cell carcinoma of the penis is what's called verrucous carcinoma. It has no relationship to HPV, it has no significant atypia, and has no potential for metastasis. Quick word about some scrotal disorders, specifically hydrocele. Hydrocele is the most common cause of scrotal swelling. Basically, what it implies is that The tunica vaginalis, the sac surrounding the testis partially, instead of being closed off from the peritoneal fluid, it's open to it, and hence peritoneal fluid will accumulate around the testis, and this is what's called hydrocele. The fluid is clear and it can transilluminate, meaning you can see the light behind it because it's clear fluid. Again, it's benign and commonly associated with inguinal hernia. The way to treat it is by closing off the connection between the peritoneal fluid and the tunica vaginalis. This is a schematic presentation. On the left-hand side, we have the healthy normal testis, and on the right side, we can see that the greenish color is representing the accumulation of fluid. Again, treatment is by closing off this connection. Cryptorchidism and testicular atrophy. This is kind of common disease among infants. Cryptorchidism is a failure of testicular descent into the scrotum. You probably remember that the testis originates from the abdominal cavity, the area around the kidney, and it descends into its final destination, the scrotum. And during that descent, it goes through the inguinal canal. Normally, the testis descends from the abdominal cavity to the inguinal canal by the 3rd month of pregnancy. And they descend from the inguinal canal into the scrotum in the last 2 months of pregnancy. Not all infants have descended testicle by the time of birth. Many normal children will have undescended testicle that will descend a few weeks after birth. That's why you only diagnose pathologic cryptorchidism only after the age of 1 year. It's kind of common. It affects 1% of the population, and it has no cause. It can be bilateral in 10% of the cases. It can be complicated by testicular atrophy and sterility. Basically, when the reason the testis is in the scrotum is due to the relatively lower temperature of that region compared to the core of the body. And this is the optimal temperature in which spermatogenesis occurs. If the testis is imprisoned within the inguinal canal or higher, then it will be exposed to a core temperature of 37 degrees, which is not good for spermatogenesis, and this will result in atrophy. And for some reason, if undescended testicle or cryptorchidism is not treated, it can result in an increased risk of testicular tumors. Interestingly, the increased risk of testicular tumors affect both testes, the one that's undescended and the one that's not. For example, if a patient has a right undescended testicle and a normal left testicle, he will have an increased risk of malignancy in both testicles. Similar to something we saw on the breast pathology. If you remember, we mentioned that ductal carcinoma in situ in the right breast carries an increased risk of breast cancer in the right breast. However, lobular carcinoma in situ, regardless of which breast it was discovered in, it carries an increased risk in both breasts. Please keep that in mind. Testicular torsion is a common vascular disturbance affecting the testis, specifically in adolescent men. It results from torsion of the spermatic cord. This will result in obstruction of the thin-walled testicular vein, but not the thick-walled testicular artery. This in turn will cause congestion and hemorrhagic infarction. Clinically, these patients present with severe pain that can be severe enough to wake them up from sleep. This is a true emergency and one of the few emergencies in the male genital tract, as release of obstruction should be performed within 6 hours to save the viability of the testicular parenchyma. This is a gross image or a macroscopic image of a testicular torsion. Notice the blackish brown color of congested blood within the testis. Testicular tumors are relatively rare. They typically affect young-ish men between the ages of 15 and 34, although again, any age can be affected. The vast majority of them are germ cell tumors, and all of them are malignant, especially in adults. and less than 5% are six-chord stromal tumors, and these are benign. The risk factors for testicular tumors include white ethnicity, undescended testicles, certain syndromes such as androgen insensitivity syndrome and gonadal dysgenesis, family history of testicular neoplasms, specifically in first-degree brothers, and previous history of a tumor in one testis carries an increased risk in the contralateral testis. The precursor lesion for germ cell tumors of the testis is something called germ cell neoplasia in situ, and it is seen frequently in some of the previous risk factors that we mentioned, classically androgen insensitivity syndrome and gonadal dysgenesis. This table represents several tumors of the germ cell category of testicular tumors. The most common by far is seminoma. Typically affects men in their late 30s to their 40s. And we will discuss the morphology soon. Although HCG is classically associated with choriocarcinoma, 10% of patients with seminoma can have elevated HCG. The second tumor is called embryonal carcinoma. Those patients are typically 10 years younger than those afflicted by seminoma. It has no specific tumor marker, and it's characterized by poorly differentiated tumor. Yolk sac tumor is a tumor of young children, and the tumor marker for yolk sac tumor is alpha-fetoprotein. Choriocarcinoma affects similar age to that of embryonal carcinoma, and all of them have elevated beta-HCG. Teratoma is similar to what we saw in the ovarian lecture. It can happen at any age. If it affects pre-adolescent males, it's typically benign. If it affects the adults, it's always malignant. Even if it was benign by histology, a teratoma in adults is always malignant, which is in sharp contrast with the mature cystic teratoma of the ovary. Again, it has no marker. And a good percentage of testicular tumors, specifically non-seminomatous tumors, are mixed, meaning they have two or more different histologic subtypes. For example, embryonal carcinoma plus choriocarcinoma, or embryonal seminoma with yolk sac tumor. Testicular tumors typically present with painless swelling. Most commonly, they have widespread metastasis if the patient has non-seminomatous tumor, while seminomas typically remain confined to the testis or the pelvic region. Tumors such as embryonal carcinoma and choriocarcinoma, they have widespread metastasis, specifically through the blood into the lung and liver. The use of tumor markers such as beta-HCG in cases of choriocarcinoma and alpha-fetoprotein in cases of yolk sac tumor are helpful in diagnosis and follow-up after treatment. The prognosis of all germ cell tumors of the testis is very good. Seminoma carries a 95% cure rate because it's highly sensitive to chemo and radiotherapy. Even non-seminomas, 90% of them have cure with aggressive chemotherapy. Choriocarcinoma happens to have a worse prognosis, although the cure rate is something close to 75 to 80%. Recurrences happen in the first 2 years of treatment, although a lifelong follow-up is recommended for these patients. Morphology, as we discussed, the tumor can be pure, meaning it's composed of one histologic subtype, or mixed, meaning it has two or more histologic subtypes. This occurs in 40% of the cases. Seminoma is the most common tumor. It has large uniform cells with clear cytoplasm, giving the fried egg appearance. It has distinctive cell borders, round nuclei with frequent lymphoplasmacytic infiltrate, which is a very helpful clue. Sometimes this inflammation can be severe enough to cause granulomas, and these granulomas can be so prominent they can obscure the tumor cells. If the tumor contains syncytial trophoblasts, which it does in a minority of cases, it can have elevated HCG levels. This is a histologic image of seminoma. Notice the large cells with clear cytoplasm, and notice the arrows indicating lymphocytes. Spermatocytic tumor is not mentioned in the previous table. It is a unique tumor. It affects elderly men in their 50s and more. Interestingly, this tumor has no lymphocytic infiltrate, no granulomas, no syncytial trophoblasts, no elevated tumor markers, no other germ cell tumors. It's never part of a mixed germ cell tumor. It has no potential for metastasis and no associated germ cell neoplasia in situ. This is in sharp contrast to other tumors. It is composed of large polygonal cells with different sizes. In the previous classifications, this tumor was called spermatocytic seminoma. In the new edition of the WHO classification, it's called spermatocytic tumor. Again, it affects men in their 50s and 60s. This is a representative image of a spermatocytic tumor. Notice that large cells in different sizes. There are small, intermediate, and large cells. Embryonal carcinoma, it's a malignant invasive tumor characterized by the presence of focal hemorrhages and necrosis. It's composed of large cells with no distinctive cell borders. They have prominent nucleoli, and the cells have different arrangements such as solid sheets, papillae, and glandular structures. Embryonal carcinoma is rarely pure. It is almost always associated with another histologic subtypes as part of a mixed germ cell tumors. As we mentioned, mixed germ cell tumors are present in 40% of these patients. This is a representative image of embryonal carcinoma. Notice the solid sheets as well as the glandular formations in the middle of the image. Again, this is associated with hemorrhage and necrosis frequently. Yolk sac tumor is a tumor of young children. It carries very good prognosis in children. In adults, it's typically part of part of the mixed germ cell tumor association with another histologic subtype. The tumor is composed of cuboidal to columnar cells with lace-like architecture, solid sheets, microcysts, glands, or papillae. It is associated with increased level of alpha-fetoprotein. And one characteristic morphologic feature is what's called Schiller-Duval bodies. They look like primitive renal glomeruli. This is an image of yolk sac tumor, and the arrows point at Schiller-Duval bodies. Notice that they are arranged. They are basically a fibrovascular core surrounded by columnar malignant cells in what appears to be a microcyst. This feature is characteristic of yolk sac tumor. Choriocarcinoma is another aggressive malignant tumor with widespread metastasis by the time of diagnosis. Interestingly, the tumor in the testis can be very small, and sometimes we cannot see it, although the patient has widespread metastasis, specifically to the lung. The tumor cells are similar to the trophoblastic cells seen in the normal placenta, specifically cytotrophoblasts and syncytial trophoblasts. You probably remember syncytial trophoblasts are multinucleated giant cells that secrete beta-HCG. Beta-HCG is a helpful marker in this tumor as it can be used for diagnosis and for follow-up after treatment. This is a representative image. Again, this tumor has plenty of hemorrhage, and the arrow points at multinucleated giant cell or syncytial trophoblast, which secretes beta-HCG. Teratoma is the second most common tumor after yolk sac tumor in children. It is benign in children, malignant in adults. Please make this distinction very carefully. Remember, in adult ovarian tumors, we said that teratoma could be mature cystic, meaning it's benign. It can be immature if it has immature cartilage or neuroepithelial tissue, and it can be frankly malignant if it has malignant tumor. However, in adult males, what appears to be histologically benign teratoma is by definition malignant. That's a very important distinction between ovarian and testicular adult teratomas. In adult males, it's always malignant regardless of the histology. You probably remember teratoma. It's composed of the three embryonal cell layers: mesodermal, ectodermal, and endodermal. Picture number A represents ganglion cells or neuronal cells derived from the ectoderm. B is respiratory or GI epithelium with mucus cells derived from the endoderm. C is cartilage, mesodermal in origin, and D is hair follicle, which is another ectodermal derived tissue. This was the end of the first lecture of the male genital tract. I would like to thank all of you for listening. Once again, stay safe and stay healthy, and please do not hesitate if you have any questions. Talk to you later.